practices focuses on bone and soft tissue regeneration and dental implants. She's also active in professional organization where she is the president-elect of the Academy of Osteointegration of American Association Oral Maxillofacial Surgery committee member, and the section of editor of the International Journal of Oral Maxillofacial Implants. So she was in Chile 2 years ago, so we are lucky to have her visit, talking about medication-related osteonecrosis of the jaw. That's why today we are glad to hear her talk with the last updates in the field of osteonecrosis of the jaw. So please, Dr. Aghaloo, you can start your presentation whenever you want.
Perfect. Thank you so much, Luis. It's a pleasure to be here. And yes, I had such a wonderful time when I visited you a couple of years ago. So thank you all for coming today. And it's my pleasure to talk to everyone about osteonecrosis of the jaws today. So we all know that osteomyelitis and other bone reactions we often see. If it's an infection in the bone, osteomyelitis. If it's radiation therapy causing necrosis, osteoradionecrosis. And of course, if it's medications or secondary to bone metabolism from drugs, then it's osteonecrosis of the jaws. And you can see here that these have different etiologies, but when you look at them clinically, they often have the same presentation. So sometimes it can be a little bit difficult to tell between osteomyelitis, osteoradionecrosis, and osteonecrosis. And these are three of my patients that I have seen fairly recently, and the differences is pretty similar. So let's talk about osteonecrosis of the jaws. So this is defined by the AAOMS all the way back from 2007, with a little bit of different definitions in 2009 and 2014 being the most recent update from the association. And so basically, as you all know, current or previous treatment with either a bisphosphonate or denosumab, one of the anti-resorptives. And this also includes other medications like anti-angiogenics, but my talk today really is going to focus more on the anti-resorptive aspects of ONJ. This is either exposed bone or bone that can be probed through an intra or extraoral fistula, and that's present for more than 8 weeks, and no history of radiation therapy. Now, one thing that I will tell you is that I have several patients, probably about 5 or 6, who have had both radiation to the jaws and an anti-resorptive. So, the question with those patients is it ONJ from medications or is it osteoradionecrosis? And so usually if I'm not sure between the two, I treat it more as if it's ONJ or medication related. So let's talk a little bit about the indications for taking anti-resorptive medications. So number one is primary bone cancer, such as multiple myeloma. And you can see here that this is a bone scan from a patient who has multiple myeloma. And all of these little areas or lesions in the spine and in the ribs and in the pelvis where there are myeloma cells, or basically cells that are like osteoclastic, and they're chewing up the bone and causing the scan to light up here. So the anti-resorptives are very effective in this disease to reduce the spread of disease, to reduce bone pain, because you can imagine the chewing up of the bone by the myeloma cells is going to be quite painful. It's also going to cause spontaneous fractures. So whether it's rib fractures or spinal fractures or hip fractures, then obviously those are going to be pretty significant and debilitating to the patients. Metastatic cancers are also indications for anti-resorptive medications, specifically breast cancer, stage 4, that metastasizes to the bones, prostate cancer as well, and sometimes lung cancer. And so of the patients that I've seen, the most common are multiple myeloma patients, and then of course breast and prostate. And when we think about the number of patients with this problem and with ONJ, it's pretty small, and most dentists will only see a couple of cases maybe in their lifetimes. Oral surgeons usually will see more, and especially those at an academic center, which many of you are from. I have about between 450 and 500 patients with ONJ that I see, and most of them I see pretty regularly, especially during their therapy and the course of treatment. Another indication is for hypercalcemia of malignancy, and this can be pretty devastating as the myeloma cells or the osteoclast, depending on which type of cancer you have, are chewing up the bone, and then as the bone is resorbed, the calcium gets into the circulation and causes hypercalcemia. And then, of course, another indication being osteoporosis, that we know millions of patients worldwide have osteoporosis, and the first line therapy is an anti-resorptive medication. And then, of course, one of the last indications for anti-resorptives is Paget's disease. And I've only seen 3 patients with Paget's disease have osteonecrosis of the jaw. So this is certainly much more rare, both in the disease itself and then in the patients getting ONJ with the treatment for their disease. And so I put this on here just so that we could see the different medications, both their generic name and their brand name, and when they were approved by the FDA in the United States. So this is how long that they've been used. And you can see that this one is pomidronate that has been approved since 1991. I almost never see patients on this anymore. I saw one patient about a month ago, and that's the first one that I've seen in several years. Most of the patients for their malignancy are either getting zoledronate or zoledronic acid or denosumab. And so those are really the most common medications now in cancer patients. In osteoporosis, we have a lot of different options, anywhere from the alendronate being once a week, risedronate, ibandronate, those are going to be once a month generally. And then we have zoledronate or reclassed, which is annually, once a year, or Prolia denosumab, that is going to be every 6 months as an injection. And I'm seeing more and more patients on one of these 2 medications because it's a lot easier for the patient to get an injection or an infusion either once or twice a year rather than have to take a pill once a month themselves or once a week with the alendronate. And so let's talk a little bit about denosumab because it is quite different than the bisphosphonates. And this is a monoclonal antibody and it inhibits rank ligand. And so basically, as many of you know, you have a receptor on your osteoclast called rank, and then the ligand is going to bind to that receptor. And then that's going to activate the osteoclast function, both differentiation and function. And so you're going to inhibit that, and then you're not going to have bone resorption. And so it's really it will bind to the rank and by inhibiting the rank ligand. And so really, essentially, if you are having denosumab, there aren't going to be any osteoclast formed. And so it's a little bit different than the bisphosphonates, where the bisphosphonates are either killing the osteoclasts or making them ineffective in their ability to resorb bone. But when you're using denosumab, which is either going to be Prolia or Xgeva, depending on the formulation, then the osteoclasts are actually not even formed most of the time. And so you can see that for osteoporosis, it's given every 6 months. And for cancer, either metastasis or primary bone cancer, it's given either once a month or once every 3 months, depending. And then, of course, there are other treatments for osteoporosis that are not anti-resorptives, such as parathyroid hormone, teriparatide, which will increase bone remodeling in favor of bone formation. And so the bisphosphonates and denosumab are inhibiting the catabolic aspects of bone remodeling. And so you don't resorb bone, and that's how you maintain your bone density. But the anabolics, as a treatment for osteoporosis, are going to increase bone formation. And so these work very differently. And so these have not been associated with osteonecrosis of the jaws. And so patients that are on parathyroid hormone or parathyroid hormone related protein, which is a pretty recently approved drug, abaloparatide, and also romosozumab, those are really not going to be associated with osteonecrosis of the jaws. Now, this last one I put in here, romosozumab, which is an antibody to sclerostin, and that's a different pathway. So the majority of the effects of this particular drug are anabolic, also just like these 2, but there's a little bit of anti-catabolic activity. So we actually just did a study in animals in our rat model to see if there were any cases of ONJ in the rats with this drug, and there were not. And so it's important that to look at that and think about that because of the minimal anti-catabolic activity, but we did not find any cases of ONJ in our rats. And so most likely that we're not going to see any in patients as well. But certainly these other two, by the way that they act, are not going to be associated with ONJ. And so super important. And again, I have to discuss this a lot with patients and with a lot of dentists that will refer patients because these medications are very different, even though they're a treatment for osteoporosis. So let's talk about the prevalence of ONJ. And, this is really all over the map. There have been a lot of studies over the years that have looked at how common ONJ is. And it's pretty rare, but the literature is all over the place. You can see that we have incident prevalence anywhere from 0.8 to 12%. It depends also how long the patient's been receiving the medication. And then for denosumab, because it's a lot newer, we don't have patients that have been on it for as long. And so we really I don't think we have a real accurate picture. And the literature reports anywhere from 0.7 to 1.7%. But I have to say that I have definitely seen more patients with that in my practice. And I think a lot of the reason is because the denosumab is more potent in general than the bisphosphonates. And so the inhibition of bone remodeling is significantly better, more effective for the therapy that it's used for. But then there are potentially more cases of ONJ that are occurring. Osteoporosis is much, much less. You can see anywhere from 0.01 to 0.1%. So this is the range that I give my patients. You can see if we're using denosumab for osteoporosis, then we're anywhere from 0.09 to 0.2%. So pretty rare. And these prevalences are going to increase if you have certain things. If the patients are having a dental infection, if they are having an extraction, or if they've been on the medications for more time and longer amount of time. So certainly that's the range I usually tell my patients, but it is a little bit flexible depending on the other risk factors. And of course, if we're thinking about the risk factors, similar to what I mentioned, the duration of anti-resorptive therapy, if you're having extractions or other dental trauma, or the patient has other factors that might affect healing, such as steroids or chemotherapy, or if they're smokers or diabetics. So one group of patients that's significantly at risk are patients with certain autoimmune diseases, such as rheumatoid arthritis, because they're often going to be on steroids or other chemotherapy. And then they're also on an anti-resorptive, either for prevention of osteoporosis, or they may have osteoporosis as well. So this is a group of patients that is also at even potentially higher risk. And then we also have dental risk factors, right? So the extractions, but also thinking about why the teeth are being extracted. And this is really the first thing that got us interested in studying osteonecrosis in the laboratory setting, because we were thinking more about why the teeth were removed rather than just the fact that they were extracted. There have been studies that have definitely supported that, where patients with poor oral hygiene or more advanced dental disease, whether it be periodontal disease or caries leading to endodontic problems and periapical disease, those patients had more osteonecrosis. And then when preventative measures were used, such as more prophylaxis, more cleanings, and other maintenance, then the ONJ was significantly decreased. And so that really leads us to think more about the patient being more at risk if they have dental risk factors and the reason that the extractions are done, rather than just simply the extraction or the trauma itself. And so let's talk about the staging of ONJ. And this is an example of a patient with stage 0. You can see that there's a lot of calculus around the teeth. So certainly not the most healthy situation, but there's not any exposed bone or any fistula, but you do have some areas of inflammation and the patient is symptomatic. And so these are really the aspects of stage 0, where it's no clinical necrotic bone evidence and non-specific findings. So it actually sometimes is pretty difficult to determine whether the patient has just dental disease or they have stage 0 ONJ, because clinically you might not be able to tell. One of the ways that we have really been able to differentiate between that is by using cone beam CT scans. One of our favorite ways, and I have some cases that I don't necessarily have time to show you today, but where we don't see any clinically exposed bone, but you can radiographically see it. And here's an example of that. You can see that we have necrotic bone, we have very dense bone, a lot of sclerosis, we have potentially even sequestra bone that are forming, even though it's in a patient who doesn't have any clinically exposed bone. And so I utilize cone beam CT scans quite often to help diagnose ONJ, especially stage 0, but also in stage 1, 2, and 3 to look at the extent of the disease, because sometimes you really can't appreciate it as well with a traditional 2-dimensional radiograph or just with a clinical exam. And this is stage 1. This is in a patient who has exposed bone, but there aren't any symptoms at the moment. There's no pain, there's no signs of infection, and so it's simply exposed bone, and this would be stage 1. Stage 2 looks obviously a bit different. You can see this is a patient who had implants and developed osteonecrosis. This patient actually came to me from the dentist where the patient said, oh, well, my dentist wants to know if it's okay to restore my implants. And so obviously my answer was no. And definitely no, no way was really what I said with a little more colorful language probably. But certainly this is a patient who has stage 2 where the bone that's exposed is associated with pain and swelling and soft tissue or bone infection. And you can see as we know that this is just a tremendous trap for plaque and bacteria. So when you have exposed bone that's necrotic, the bacteria and the plaque just really attach to it very well. And so this is sort of the basis of that whole inflammatory or infection hypothesis that leads to necrosis. And then, of course, stage 3 is even more severe with extensive exposure and infection or pain that's really not manageable with just antibiotics. And you can see that it's beyond the alveolar bone. So you can see that we're at the inferior border of the mandible. This is a patient that has a pathologic fracture. And so certainly patients who are much more severe and the stage 3, fortunately, is a lot less common than stage 1 and 2. And then you can see this is that same patient with the pathologic fracture. This is during the treatment where the patient had an extraoral incision. And you can see once you expose the fracture that all the necrotic bone in the area. And so certainly with a fracture like this, the patient's going to have a resection of the mandible. But one of the questions always is, even though the ONJ is limited to this area, how is the rest of the bone? And certainly it looks normal, but is it going to be able to remodel normally? For example, if you're going to use a reconstruction plate with screws that have to go into the bone, or maybe if you're thinking about doing a bone graft, whether it's a free graft or vascularized, all of that has to remodel and heal at the edges. And so are we going to be able to do that in a patient who has compromised healing because the coupling of the bone resorption and the formation are not happening appropriately because of the lack of osteoclasts or the lack of osteoclast function? And so when we think about treatment, what kind of evidence can we use to really inform our treatment protocols? Because still osteonecrosis was identified in 2003, was the first time it was reported, 2003 and 4. And so it really hasn't been around that long to really have our treatment perfected. And so we have to use our research and our translational studies to help inform our clinical practice. And so I'm going to talk a little bit about that now. And so a couple of the ways that we handle ONJ is either one, can we minimize the risk? And then obviously if patients have ONJ, then how do we treat that? And so what evidence can we use from some translational studies that are available? And so let's talk about the first part first. And like I mentioned to you, we already know that inflammation and dental disease is a risk factor and is really the reason why teeth need to be extracted. And so this is what we started studying, and this was our first publication in 2011 to look at exactly that. What is the pathophysiology of the disease? And what we found was that periodontal disease and a potent anti-resorptive is both necessary and sufficient to induce osteonecrosis. And we also did studies where we looked at periapical disease from an endodontic problem and found the same type of picture. And this is showing our rat and a patient of mine and how similar this looks on the CT scan. This is a micro CT and this is a cone beam CT. And you can see that we have very sclerotic bone, like we in both of our human and rodent patients. We have a lot of periosteal bone formation that you can see both in the rat and the patient, and from the axial view, the coronal and the sagittal views. And that was the same as the histology. So these A and C are from the rat, and you can see, if you look at the high power, you can see inflammation. We can see bone sequestrum and necrotic bone, and the same thing in our patient, which is here and here. And so what we found was that it was very similar. And as I said, we did the same study in looking at periapical disease, and the same picture was seen. So what about translational studies in terms of treating ONJ once patients develop it? And so you can look at things like parathyroid hormone. Now, remember, I said that the pathophysiology is the inflammation, but it's also the lack of bone remodeling. And so when we think about treatments that can affect bone remodeling in favor of bone turnover and remodeling, parathyroid hormone is one of those drugs. And the way that it works is that it increases bone remodeling in favor of bone formation. So it will activate the osteoclast to remodel and resorb bone, and then that coupled formation of bone that comes right behind it. And so fortunately it's anabolic, and so it's going to be building up bone, and that is how parathyroid hormone works. And it's been shown in animal studies to increase that bone formation, also suppress inflammation, and increase collagen synthesis. So potentially, because it's seen in animal studies to have this effect, then would it be effective against ONJ? And so this study, actually, that was done quite a number of years ago, but was very, very nice study, looked at patients that had saline and then no parathyroid hormone and had an extraction. This is in mice. It was either mice or rats. I think it was mice. And then the tooth was extracted and they were given parathyroid hormone. And you can see the blue is the bone formation here inside the extraction sockets. However, when you give alendronate, which is like Fosamax, the bisphosphonate, and they were also given dexamethasone, a steroid, you can see that this is the outline of the extraction socket where really minimal to no healing occurs. But if parathyroid hormone is given, then the socket fills in and it heals very well. And so again, really reversing some of those effects in the animals. And so would that work also in patients? And of course, the answer potentially is yes. This is a case series of patients, and there have been several case series and case reports looking at this very thing, where you have osteonecrosis, fistula, and exposed bone, which on the CT scan shows a sequestrum. And then after parathyroid hormone treatment, the area will heal, generally because the sequestrum will eventually exfoliate because of the increase in bone remodeling, and then the ONJ is essentially gone. But the problems with PTH, or parathyroid hormone, is that it's contraindicated in cancer patients. So it really only can be used in osteoporosis patients. It's also, there's a risk of osteosarcoma after 2 years of therapy, which is why even for patients with osteoporosis, the parathyroid hormone treatment time is limited to 2 years. Now, there haven't been any cases of osteosarcoma in patients since it's been approved. And parathyroid hormone is an FDA-approved osteoporosis treatment since 2002. So it's been almost 20 years that it's been used, and there haven't been any cases of osteosarcoma that have been reported. However, it's been limited to 2 years of therapy. The one thing that is very difficult with parathyroid hormone is it's very expensive. It's like $30,000 a year for this treatment. Whereas if you're looking at a treatment such as alendronate, it's about maybe a couple $100 a year at most. So obviously a very big difference in the cost, and most of the insurance companies are not going to pay for that or cover it. And the patients obviously are not going to have enough money for that. Now, but it's something to think about. And I've had quite a bit of success using this in certain patients, especially if they need to continue with their osteoporosis therapy. And so I generally will write a letter to either their insurance company or their primary physician, who will usually eventually be able to get it covered. I had one patient who wasn't able to get it covered, and they actually paid out of pocket for the parathyroid hormone treatment. So, certainly something to think about. So should we use these in a clinic setting? And, this is the last position paper by the AAOMS that was in 2014. And it really goes over the recommended therapies for osteonecrosis of the jaws, depending on what stage of disease it is. And so I'm going to go over those for you right now. And so our objectives, of course, of therapy are several. Number one is to eliminate pain. You can see when you have exposed bone and you get plaque and bacteria on this exposure, it causes swelling of the tissues, it causes redness, and oftentimes there's going to be pain, especially, sometimes pain all the time, other times just when the patient is eating or touching the area. We want to certainly control the infection and the inflammation in the surrounding tissues. We want to minimize the progression of necrosis. And then we also want to educate the patient. A lot of times patients now are very educated and they've done their research either by going online, or maybe they've talked to other patients, or maybe their primary physician or oncologist has talked to them about ONJ. But really coming from the dentist, it's really much more effective in terms of educating them on what to expect, what kind of therapy, and to talk to them about their options. And you can see here, this is really one of the most difficult areas to treat, the posterior maxilla. And the reason is because the sinus is right in the area. And generally, if we were to go in and do any kind of surgery, we're going to cause an oral antral communication. And those of you who have patients with them and have tried to treat it, it can be very, very challenging, especially in someone where it might not heal, such as in a patient with osteonecrosis. And so when I see someone that has a ONJ in the posterior maxilla, it's really the most difficult area in my opinion. And so how do we prevent ONJ? And like I said, if we can ever get a hold of these patients early on before they start their anti-resorptives, this is really what's most ideal. If they can get a good clinical dental exam, including radiographs, detect any infections, extract abscessed or non-restorable teeth or ones with severe periodontal disease so that those aren't at risk either from the periodontal disease or from the extractions themselves. We want to rehabilitate the salvageable dentition because, again, sort of similar to when someone's going to get head and neck radiation, they go through a dental exam and really have their teeth all taken care of as much as possible so that they're not going to be at risk for developing necrotic bone after therapy initiates. And then, of course, we're going to really educate our patients and reinforce hygiene and signs of disease so that they can come in sooner rather than later. During therapy, if they're already on systemic therapy, especially if we're thinking about patients that have cancer and they're on either intravenous or subcutaneous denosumab, we want to avoid invasive dental procedures. And these would be things such as apicoectomies, periodontal surgery, implant therapy, or extractions. So certainly those are really things that we should be avoiding if at all possible. We want to maintain their routine dental care. I don't know about in Chile and how things are there, but here there are a lot of dentists that don't want to see patients that are on anti-resorptive therapy because they're afraid they're going to induce ONJ. So some of our job often as oral surgeons is really to educate the dentists out there, especially the ones who maybe haven't learned about this either in dental school or in their continuing education courses, about that really maintenance dental therapy is so important, and even more important in patients who are on this medication because we don't want them to need to have extractions. We want to ensure that their dentures fit well because certainly a denture that's rubbing on the tissue can cause an exposure and an opening, and then we're going to have an ONJ situation. And then, of course, if we have dental infections, we want to aggressively manage them, such as with root canal therapy and antibiotics. And then we need to continue to have regular dental visits. So these are the treatment strategies that have been set forth by the AAOMS, and these are the clinical guidelines. You can see the stage from 0 to 3, and generally stage 0 and 1 are going to be managed with an antimicrobial rinse and regular follow-up, possibly pain medication and antibiotics if we have either symptomatic stage 0 or symptomatic stage 2. In stage 2, the AAOMS is recommending debridement, and in stage 3, larger surgical debridement or resection of the jaw. So the reason that surgery, I think, has been recommended for, especially in that last clinical guidelines that I showed you, is because classically non-operative therapy, so-called conservative therapy, has not been very effective. And you can see here success rates in these publications anywhere from 15% to 60%, maybe up to 80% in terms of decrease in pain. And so these numbers are not that great. And so, of course, it would make us think that maybe surgery would be more effective. But if you look at this, the studies are still pretty limited. And how do we define success? Is it mucosal healing? Is it absence of pain? Is it lack of infection? And so the criteria for evaluation is pretty much all over the map. And so I think that often contributes to the confusion with the non-surgical therapy. And surgical therapy has been shown to be effective. You can see if you look at this table here, the surgical effectiveness has been pretty significant, anywhere from, in the 70s to, high 60s, high 80s, all throughout the gamut. Obviously, some of these studies maybe not as much, but certainly the numbers look higher than in the classic non-surgical therapy. But what about the surgery? I mean, surgery is pretty aggressive, and oftentimes these patients are very sick. They have either metastatic cancer or potentially very debilitated from their osteoporosis. I mean, the average age of my patients that have ONJ is, in the high 70s and often 80s. And so this is a patient population that is pretty compromised. And so I don't really know if a large debridement procedure or a resection is such a good idea in a lot of these cases. And so I'm often thinking of, can my patients tolerate a surgical procedure? And so are there any other options? And of course, we're thinking about that and utilizing the research that we've done to try to think of how else we might be able to manage these patients. And of course, as I said, surgical therapy is effective. This is a particular case years ago that I treated, where it is a patient who had metastatic prostate cancer. He was having pamidronate once a month, and he was referred from his dentist because he had necrotic bone and pain in the lower left area posteriorly, and he had failed conservative treatment. So when patients come to me, though, I'm always wondering, what is this conservative treatment? Is it just rinsing with Paradex? Is it just, what is it exactly? And I think that that's sometimes where we need to know a bit more information. And so you can see here that this patient, again, presents with a lot of purulence and exposed bone. He's not really taking good care of the area. And so obviously it's pretty uncomfortable. And one of the most difficult things that I see is oftentimes the bone that's exposed is very sharp and it's poking and ulcerating the tongue. And so certainly that's an area where you can easily take out a bone file and just get rid of that sharp area. And it can really make a big difference with the patient. And so you can see here when we look at the panoramic, we have pretty extensive necrotic bone. You can see that it goes almost to the inferior border and all the way up, halfway up the ramus. You can see when we get the cone beam CT scan, it's even a bit more defined how close it is to the mental nerve. Obviously, it's in the inferior alveolar nerve. And so most of the time, these patients are going to have paresthesia or anesthesia on that left side. And so when we're going to go in, if we're going to do a surgical procedure, this is going to need to be a resection. And so this would be approached usually extraorally. And we can see that we either can pre-bend a plate or we can have a custom plate that's made to make the surgery a lot faster. As I mentioned, this is a pretty medically compromised patient. So any way that we can decrease the surgical time is going to be something that is favorable and desired. And so you can see the resection, and again, the margins oftentimes are, where do you draw the line? It's not like osteoradionecrosis where we're resecting to bleeding bone, because remember, ONJ is not a vascular problem. It's a problem with the remodeling of bone. And so how do you know where the remodeling margin ends? I really think that that's a very difficult, very challenging aspect when you're thinking about doing surgery in these patients. This is our reconstruction plate. So again, I'm concerned. Are these screws going to integrate into the bone? Are they going to cause osteonecrosis in the areas where we've put the screw? Because again, we're drilling into bone that may not have proper remodeling capacity. And this is generally why bone grafts are not done at the time when resection is performed, because again, where is the margin and is it going to heal at the resection edges? And so in this patient, he went on to heal and do very well. He has no exposed bone here anymore. Everything's healed. The plate is in place. But again, without having a bone graft here, how long is that plate going to hold up? These reconstruction plates are not really meant to support occlusion and eating. I mean, this patient, he doesn't have a full complement of teeth, but he's certainly chewing and biting here. And you can see he's pretty much has an edge-to-edge occlusion, as you can see from that. And so he's going to generate a good amount of force that is going to put a lot of pressure on that plate, and eventually the plate's going to fracture. And so this is really what I do for the majority of my patients. And this is really what we started looking at when we thought that the conservative therapy isn't working and the surgical therapy is too aggressive for most patients. And so is there another option that can be based on some translational findings? And remember, we said that we know that ONJ is an infection or an inflammation as one of the major causative factors. And so can we eliminate this local noxious environment around the area of diseased bone, and can that lead to resolution of the disease? And so this was a study that we did published in 2018 in the Journal of Oral and Maxillofacial Surgery. And so this is a video just really showing, this is, how I would be cleaning the exposed bone. And when we have a sequestrum that really presents itself, then we'll actually go in and just remove that sequestrum. And you can see here, this is cleaning the area of the bone. When it's this mobile, then I will really utilize a Q-tip with the Paradex or chlorhexidine on it, and remove the sequestrum of bone with cotton pliers. So this is really the extent of my surgical debridement. That's it. So I'm not really doing much more than that at all, and we can get that to come out and be removed. So I think that it's important to make sure that we understand that we're cleaning the area very well and using this sequestrum removal when it's mobile enough to do that without surgery. So this is a couple of cases as examples. You can see here, this is a patient that has stage 3 ONJ, and this is that dreaded posterior maxillary area. So if I were to go in surgically and remove all of this bone, we would have a pretty significant. Sorry, if people aren't muted, could you guys mute yourselves? Because I do it. Thanks. And so you can see here that if I were to go in and do a resection or even debride this area surgically, we'd have an opening into the sinus. And once you have an opening into the sinus, it's so difficult for that patient to keep clean and to keep it from getting a sinus infection. So we treated this with the local aggressive wound care with the Q-tip, or you could use a small toothbrush or something, anything to scrub and decontaminate the exposed bone that has all this plaque and bacteria on it. And of course, we get the cone beam CT so that we can define the extent of the defect. And eventually, this whole giant sequestrum of bone comes out on its own and then leaves this area here, usually without a sinus communication. So this patient did not have an opening into his sinus. It closed, it had mucosalized underneath. The mucosa had healed there and basically kicked out the sequestrum of bone. And once it was removed, then he was able to go on very well. And I actually just saw this patient today. This was about probably 3 or 4 years ago now that this had healed. And I saw him today, and he's doing very well. And so this is a CT scan afterwards. And remember, it showed that there was, either very little or no bone above that area, but there's still here a barrier and not much sinus infection at all, just a little bit of inflammation in the sinus. Certainly there's a defect and this bone is not normal, but he doesn't have a sinus communication. And to me, that's huge. And we could not have achieved that with a surgical therapy. This is another patient of mine who you can see that she comes in, it looks like she has a swelling, maybe an infection in the left posterior mandible. And her history was that she has metastatic breast cancer and she's been on denosumab. She previously had implants in sites, the upper left premolar and lower right molar, but since she had her cancer therapy, somebody did an implant in the lower left. And I don't know if it's because maybe the dentist thought that she had already had 2 successful implants and so it was okay, or why that would be. But certainly doing the implants after the initiation of anti-resorptive therapy for cancer is not a good idea. And so you can see when we look at a panorex, I mean, yes, you can see maybe the bone's a little more dense here, and you can see some periosteal bone formation. But other than that, it's really hard to tell exactly what's going on. And these are the implants here and here that were placed before her anti-resorptive therapy. And this is the one that was after, where the ONJ is. And so this is what it looks like if you get a CT scan. The CBCT is going to show you much more extensive. You can see all this periosteal bone formation, the significant sclerosis, and a big sequestrum that's really connected to this implant here. But when you look at her clinically, it looks like this. There's only a small area of exposed bone. Now, clearly, clinically, she had pain. So this would be stage 2. But when you get the CT scan, I think you can say that it's actually stage 3 because of the extent, and that it goes beyond the alveolar bone and down to the inferior border of the mandible. Now, what happened over time with this patient is that her cancer actually got significantly worse, and she was having a hard time really cleaning the area. And so you can see this initially is around the implant and even a bit of exposed bone by this tooth here. So over time, it became like this. And usually if I'm giving this lecture live, or maybe you all at home or wherever you are saying, oh my gosh, it looks terrible, it's so much worse. But the fact is that it's not. This was already a large sequestrum of bone, and the ONJ extended much beyond what was exposed. And so this is actually, I think, better, because this means that now she has much better access to get to it and clean. But you can see here that she was very worried and concerned when this happened. And so she stopped cleaning it all. So you can see there's all this plaque and bacteria all over the exposed bone. And so one of my jobs really in seeing these patients and seeing them fairly regularly, usually on like a 3 or 4 month recall, is being kind of a cheerleader for them and telling them, no, it's okay. You know, you got to keep it up. You have to clean this. It's not that the ONJ is getting worse. We already saw it on the CT scan previously. And so this is really just the same thing. It's just now more exposed for you to be able to get in there and clean it really well. And so I encouraged her to clean the area, and she's using actually a toothbrush on here with the chlorhexidine and scrubbing all of this. And when she began doing that, then it actually got much cleaner, and it led to this sequestering and coming out. And you can see this is the whole piece that came out with the implant, because it was intimately associated with that implant. But then what does it look like underneath? And this is actually really impressive. You can see that there was new mucosa that had healed and formed underneath that sequestrum of bone as it kicked it out and exposed it. And when it fell out on its own, it was already very well healed. And you can see the bone as well. Now, this is not normal bone. It's not like we're going to go in there and place an implant into this bone, certainly not. But you can see here that this defect in the bone and the sequestrum has removed, and there's no other sequestrum at this time. So it's certainly a really great option, I think, for this patient. If she had had the surgery for stage 3 ONJ, it would have been a very large resection. She would have lost all of the teeth over there and been much more debilitated. And certainly she was a very sick patient and with metastatic cancer. And so when we looked at our patients, there were 117 patients in this study, and this is the distribution between stage 1, 2, and 3, certainly stage 3 being much less common. And the majority was stage 1, and stage 2 is a pretty close second. And with this method, the local aggressive wound care, we saw complete resolution in 71% of the patients, improvement in the disease in another 22%, and only 8% that progressed. And you can see half of those were stage 3 patients. So even still with stage 3, I generally am giving them a trial of this local aggressive wound care, unless, of course, they have a pathologic fracture. With that, you're really stuck, and there's nothing you're going to be able to do other than a resection and putting on a reconstruction plate. So really, the study was really helpful in determining. Now, they were also, if they had infection, they were also given antibiotics. And so they will, if they are infected or if they're having a difficulty with their wound care, then I'm giving them antibiotics as well. And we'll talk about which antibiotic in a minute. And so really what this showed was that if they had improved wound care, we did a wound care score on all of these patients. And if their wound score was much better, then they were healing significantly faster. And so here you can see the patients who had a low wound score, meaning they had little bleeding and little plaque and bacteria and very good wound care. And they healed significantly faster than the ones who were not taking good care of it. So sometimes if you have those patients who are not able to clean it, maybe it's because of their primary disease and they're too debilitated, or maybe they have severe arthritis and their dexterity of the hands is not good, or their vision is challenging, then they may not be able to clean it very well. And so sometimes you have to enlist the help of a parent or a child or a caregiver or a spouse or someone to really help with that wound care if we choose this treatment method. And so I want to leave you with some take-home protocols of really how it's best to address ONJ and prevent it as well. So there certainly are a lot of things that we have to think about, and I'll go through those right now, and then we'll have some time for questions. So I think that it's important when you diagnose ONJ to really make sure that you get the full picture. All of us, of course, are taking a full history and doing a clinical exam. It's important to identify the extent of the exposed bone, if there are fistula present, whether it's going to be intraoral or extraoral fistula, if they have paresthesia, if they have pain, where it's tender, if there's bleeding, if there's purulence. So really getting that full picture in terms of your history and exam. Radiographs. The radiographs really have to evaluate the extent of disease. And to me, it's very difficult to do that with only 2D imaging. And so I'm getting 3D imaging and a cone beam CT scan on all of these patients. And I think that it's also difficult to get a medical CT scanner. The resolution of those is not as high. We're often getting a lot of scatter from, if their patients have other restorations. And so the cone beam CT scan is just a much better way to really look at the extent of disease. And it can see all of these things that I think are harder to see on a medical CT scanner. Such as sequestra, increased bone density. They definitely were looking at the lamina dura and how sclerotic it is. You can look at the trabeculation of bone. You can look at that periosteal bone formation, crater-like defects, inflammation in the sinuses, obviously if there's a fracture of the mandible or an oral antral communication. And then it can help us to diagnose dental disease as well. There's really no need for a biopsy. The days of doing biopsies for ONJ really should be gone. Now, I will say that I've had probably in the last maybe 5 years, 1 or 2 instances where I've done a biopsy. And that's because the oncologist was concerned that it might be a metastatic new lesion. So I had one of my patients was one that had prostate cancer. And his oncologist wanted me to see if it was in fact a metastatic lesion because he was considering doing radiation to the jaws for that. Okay, so that's really the only time. And then one other patient I had potentially the radiographs made the lesion look like it could have been an osteosarcoma. And so I did a biopsy of that to differentiate. Other than that, we should be able to diagnose ONJ from our clinical exam and our radiographs where we don't need to do a biopsy. And then thinking about disrupting anti-resorptive therapy. ONJ is manageable, as I showed you. We don't need to do surgery when they have it. We can manage it with this aggressive wound care and maybe antibiotics. And so I think that stopping the anti-resorptive is often not necessary. Is specifically if it's a bisphosphonate, if you stop it, it doesn't really help it heal faster anyway, because remember the bisphosphonates will stay in the bones for about 10 years or more. So if you stop it because the patient has ONJ, it doesn't necessarily mean that the ONJ is going to heal any faster. So I think that, stopping the drug really doesn't make a whole lot of sense. We did a study in animals that I didn't show you because obviously I didn't have time to show you everything I could say about this, but we did a study in animals looking at the differences between bisphosphonates and denosumab once you develop ONJ. And really what we found was that if you stopped the denosumab before you got ONJ, if you were going to do some teeth extractions, it would potentially go on to heal. But once you had bisphosphonate therapy, because of the fact that it stays in the bones for so long, stopping it really didn't change the picture. So again, for that, I really don't think it makes a lot of sense to stop it, unless you decide that you have an osteoporosis patient and they're going to be treated with parathyroid hormone instead. And certainly in that case, you would stop the therapy. General principles: consider non-surgical management instead of surgical therapy. Now, if it's a patient who really can't do the wound care, or really has some type of reason, or just wants to have a treatment where everything's done at once, because sometimes these cases of the non-surgical therapy can take some time, then certainly you can offer that as a treatment option. And it's an option. And so, there are many, many surgeons out there who, want to do surgical therapy, and the patients want that. And I think that's fine. But, I really just want people to think about this non-surgical therapy as an option and offer it to the patients. The faster the healing would be determined by how good the wound care is. If the patients can't do that good wound care, then it's not going to heal very well. And so certainly, again, something to think about and to let the patients know. One thing that I've definitely found in my patients is they like this treatment method because it puts them in control of their disease. When you have cancer, especially, you're not in control of very much in your life with this. And so putting them in control of being the ones that are taking care and doing the wound care and being in control of that, I've often found that it's very positive in the overall cancer experience, something that they can do to improve their ONJ and potentially help it heal faster. And so I think that that's been a positive force in some of my patients. As I said, the wound care delivery might not be by the patient, him or herself. It might have to be done by a spouse, by a child, by a caregiver. And so having these options and bringing those people to the appointment and actually demonstrating how to do it is really helpful. So I do that quite a lot. Demonstrate it, definitely. Aggressive treatment when there are signs of inflammation or infection, and the wound care has to be aggressive. So you have to get in there and scrub, scrub, scrub. I tell them, I use the analogy of flossing. If you floss your teeth and your gums bleed, it means you have to floss more, not less. And so if you're delivering the wound care and it bleeds or there's pus or anything, you have to get in there more. You have to get deeper inside. You have to scrub it harder. You have to get under the margin of the wound. And if you can really articulate to that to the patient and the caregiver, whoever's helping him or her, then that makes a lot of sense and they understand. If they need antibiotics, these are the antibiotics of choice. Amoxicillin is the most effective. And really it needs to be, when you do a course of antibiotics, it has to be for at least 3 weeks. Because the bone is necrotic, the blood flow is not going to get there as quickly for the antibiotic to get to the site. So 1 week of antibiotics or 10 days is not going to be very effective. So they need to be on 3-week courses. I have some patients who need to cycle and they have antibiotics every few months because maybe their chemotherapy, when they're on the additional chemotherapy, then their wound care is affected and they're, not doing as well. Or sometimes they have a flare up. And so I am giving patients multiple courses of antibiotics oftentimes. And then the backup antibiotic, if they're allergic to penicillin, is doxycycline. I don't find clindamycin to be very effective. There was a study a number of years ago that looked at doxycycline out of USC in Los Angeles here that evaluated doxycycline and its effectiveness. And I've definitely seen that in my practice, that it's more effective than things like clindamycin. And the patients don't need to be on bigger gun antibiotics. They don't need to be on Augmentin. They don't need to be on Levaquin or any of these other drugs. These are sufficient. A lot of patient reassurance and education. So it's really, really important that we do that and see them regularly to see how they're doing and give them encouragement when they're doing well, or tell them that they need to be more aggressive when they're not getting in there enough and being as aggressive as they need to be with their wound care. And like I said, they might require multiple courses of antibiotics if there are flare-ups. And our goal of therapy is to get to stage 1 or completely have resolution of the disease. Routine dentistry is necessary so that maybe we don't have to extract teeth in the future. There's really no evidence for any of these other therapies, lasers, hyperbaric oxygen, ozone, PRP. The most difficult things that I see is when patients have had multiple little procedures and someone's attempted to do primary closure to cover it. problem with primary closure, especially if there's necrotic bone, is that now you've made a trap where bacteria and plaque can get inside, but it can't get out. So they can't clean very well. And so those are the hardest patients that I have. Unless you're going to do a big surgery to debride very largely or resect, don't try to close the wound over the top. Keep it open so that they can do good wound care. If it's refractory, sometimes they might need IV antibiotics. Sometimes if a swelling has developed, whether it's extraoral or intraoral, I'll do a small incision and drainage to clean it out and then have them be able to get in and clean. Not a surgery to remove the dead bone, but to release the pus or give them an access to be able to do the wound care. And then again, we don't want to stop the anti-resorptives without the primary physicians being involved or the oncologist saying that it's okay. Even like I said, it's not necessarily going to help the ONJ heal faster. And we certainly don't want them to have hypercalcemia or have a fracture of, the pelvis or the spine. And then when we all know that when people are taking denosumab for osteoporosis, if you stop that, there are many cases that have been reported of multi-level vertebral fractures. So we certainly, as the dentist or oral surgeon, we don't want to be responsible for that. So we really should consider that and not have them stop their drugs. If they have malignancy and no ONJ, we want to make sure we get all the information about their medications. We want to focus on routine dental care and have them go more frequently, aggressively manage caries and periodontal disease, and again, do not disrupt their anti-resorptive therapy. But surgery is contraindicated. So these are not patients that have ONJ. These are patients that are on an anti-resorptive with cancer. And so we shouldn't be doing extractions. We shouldn't be doing periodontal surgery or apicoectomies or implants. If a tooth has to be extracted, we should be cutting off the crown and doing endotherapy on it. And sometimes this is difficult to really get that point across to our endodontic colleagues, because I often hear, well, the tooth is not restorable. So why am I doing a root canal? And so we have to tell them it's being done because we don't want the infection to get from the tooth to the bone, not because we're trying to restore this tooth. And so oftentimes a conversation with the dentist or the endodontist who's going to be doing the root canal is very helpful. If patients, again, have osteoporosis and no ONJ, then we have to think again, don't disrupt the anti-resorptive therapy, but surgery is not contraindicated. Remember that the incidence is very, very low in osteoporosis patients. So there's not necessarily guidelines where you have to stop the drug ahead of time, but you can think about it, okay? And the patient has to know that they're at risk, although it's a small risk. This is what I do. I'll either do a 2-month holiday with the bisphosphonate, or when they're on their denosumab, I'll go toward the end of when they're supposed to get their next dose, do my procedure there, and delay their next injection. And of course, that's done with the primary care physician's consent. Okay, because we want to limit the effect on bone remodeling. And so when they're coming to the end of the course, when they're supposed to have a new injection, that's a good time to do it. In the first 3 years, there have been very few cases of ONJ reported, so maybe you don't need to do the drug holiday there. And the CTX test, really, I have not found that there's literature to support doing that. The CTX just tells you how much remodeling there is in general throughout the body. It doesn't tell you anything about the risk for ONJ. Now, if there later on are more studies that show that it is effective, then certainly I would consider having that test. But for now, I'm not convinced from any of the studies that there is a necessity to do this. So if they have ONJ, whether it's a patient that has cancer or has osteoporosis, we don't want to do extractions in patients who already have ONJ, certainly. We'll again endo and cut off the non-restorable tooth, no surgical procedures, and then consider prophylactic antibiotics, especially maybe during their chemotherapy cycle, if they are taking other chemotherapy drugs, such as anti-angiogenic medications or steroids or any of these others. No PTH in cancer patients, we already talked about this. And then in prostate cancer, they can't get vitamin E. So if anybody's using the vitamin E and pentoxifylline, then, again, I don't think that there's any evidence for that in ONJ yet. There are certainly some studies that are going on now. So that may change things when we see the outcome of those studies. But right now, I'm not convinced that that's helpful. But if you are using that in patients with prostate cancer, that shouldn't be utilized. If patients have osteoporosis and ONJ, again, the same thing, no surgeries, no extractions, endodontic therapy, and cut off the tooth. Again, do not stop the anti-resorptives, but if patients have already had bisphosphonates for 5 years, sometimes the primary care physician will stop the anti-resorptive and see how stable their bone density is. And that, again, is up to them, not up to us as the dentist. And then if they still require osteoporosis treatment, we might consider using parathyroid hormone if their insurance would cover it. And then if, with the consent, of course, of the primary physician. So if we have stage 1 ONJ, we want to do that local aggressive wound care that we talked about with the chlorhexidine that I showed you. Remove all the plaque and debris from the exposed bone. And there are a lot of different hygiene aids that can be used, whether it's the Q-tip or the cotton swab on the wood handle, whether it's a small kid-sized toothbrush with a little tiny head, whatever it is that you use to get in there and really clean very well. Clean all around the margins of the exposed bone, not just on the bone itself, where it interacts and interfaces with the tissue, both on the buccal and the lingual. If there are any sharp areas that are poking the tongue, you can just use a bone file and just file that down. Educating the patient, of course, so that they understand why they're doing this and what the goals are. And then no antibiotics, certainly if it's stage 1. Stage 2, again, the same thing with that local aggressive wound care. We may need the antibiotics if they have a flare-ups. And I usually, the first time the patient comes to me, if they're in a lot of pain, I usually will give them antibiotics for 3 weeks because that will help calm down the infection and make it easier for them to go in and clean the area. If they're in a lot of pain, then they're not going to do a good job with their wound care. So the antibiotics will help calm that down and help them be better with their wound care. Remove all the plaque and debris just like for stage 1. Clean all around those margins. And then if there are little fistulae throughout intraorally, break that up with the cotton swab as they're doing their hygiene. And so that's one of the things that I do when they come in for their visit with me is that I clean it really well. I get in there, I break up any areas of swelling or fistulae, go inside there. I use the I use the analogy of cleaning a toilet, which I know seems strange, but if you, let's say this is the little cotton swab, go inside to the little holes, spin it around, in and out, and really clean like you're cleaning inside a toilet, scrubbing around, going in and just debriding and cleaning it as well as you can. And sometimes you might have to even do a little incision and drainage of the swelling. Do not attempt primary closure like I talked about. If you close it primarily, it's just harder for them to get in there and clean it well. And then, of course, the patient education. This is a patient of mine that I had a number of years ago, and he actually had an angiosarcoma on the scalp. And so they gave a bisphosphonate because they didn't want the tumor to erode into the bone adjacent. So it wasn't even really a traditional use for an anti-resorptive, but that's what he had. And so he developed ONJ. You can see that we have this really sclerotic bone, some sequestrum forming here. And this is what it looked like clinically. So it was a pretty large area over a torus. And he had a really hard time cleaning around it. His cancer was pretty extensive, and he was having a very hard time with his wound care. And so, this tooth got looser and looser over time, and he would come in and would beg me to do an extraction every single time he would come in. It really hurts. I can't clean it well. Please, can you extract it? Can you extract it? And so finally I gave in, which I usually don't do, but the tooth was very, very, very loose. And so I said, okay, well, I can take it out. I didn't have to use much pressure at all. I didn't even really use a forceps for very long. I just basically took it out in like 1 second. And so this is it here once the tooth came out. And you can see here that, the bone was very dense, but there's some bleeding in there. But, again, like I said, ONJ is not a vascular problem. And then the tooth came out with some bone attached to it. And what happened to the patient is that within, about a couple of weeks, he came in and he developed a mandible fracture right in the area where I extracted the tooth. And so, even though I didn't use much force at all to take the tooth out, I caused this fracture, right? And so you can see here that now he's even more miserable than he was before. And this fracture, you can see that the extent is significant. The bone that is necrotic is much more extensive, and I put him in much worse situation by extracting this tooth. So, nevertheless, I don't do that anymore. No matter how much they beg, they can get endo and they can have the tooth cut off at the gingiva, but I'm not doing any extractions. And then, of course, stage 3, which is a little different. If it's not a mandible fracture, I will do the same procedure. The local aggressive wound care, the antibiotics, again, cleaning all around the area. But if they have a pathologic fracture, then we are going to need to treat it. So obviously, if the mandible is very thin, they're going to need to be on a soft diet because they're at risk for fracture, even just by eating. If there are any fistulae, especially like an extraoral, then I'll oftentimes drain that, so then they don't have the buildup and the pressure of an infection. And then if they're having a pathologic fracture, then we need to resect that. And these days we're either getting a 3D model and pre-bending the plate or using a custom plate. Okay, so I'm going to end with the last patient to show you about an example of that here. So this is a patient of mine with metastatic breast cancer. She's getting monthly denosumab. She's in remission with her cancer, but still receiving the anti-resorptives. And so she somehow, I'm not sure how, but had a full arch of implants. Okay. And then she comes to see me a year after implants are done. Not by me, obviously. So you can see she has a hybrid prosthesis on implants, even though she has metastatic breast cancer and is on a monthly anti-resorptive. So first of all, a no-no. Okay. That should not have been done. And so it's really hard to see what's going on because the prosthesis is there, but certainly you can see that there's some inflammation here, an infection going on, but she's in a bit of pain. So this is how how everything looks. So these are her implants, and you can see that we have a sequestrum that's forming, and it's mostly around this one posterior implant. And so she, I had her on this wound care, but again, it's very difficult because she can't get under this large prosthesis very well. So she's going along for a few months, and then she comes back and she has swelling on her face. So this is the x-ray that I got at the time, the CT scan. You can see a sequestrum and some periosteal formation. So she's probably a stage 3 because it goes all the way to the inferior border. So she comes back about 6 months later, and this is much more extensive. Okay, actually, the mandible is fractured right now, and you can see that pretty clearly. And on the CT scan, you can too. You can see the fracture line here and the fracture line here. And so we know now that we're going to have to do a resection of the mandible. We are using virtual surgical planning where we're going to resect it and have a custom plate that's ready to go on at the time. This is our resection margin. She really, really wants to keep her implant prosthesis, so she doesn't want to have that removed. And so we're going, posterior to that implant that's more anterior to the one that's affected here. So this is our pre-bent custom plate. And so I had her in the meantime, while we were planning for the surgery, I had her dentist actually take the prosthesis off, and he cut it off so that this implant is not going to be in use. Okay. And so now she's actually able to do the wound care while we're waiting to schedule the surgery and having the custom plate made and all that. So this is what happens. It's a large area of exposure, and she's able to clean around it really well. So what happens is that, the wound care is effective, and this sequestrum with the implant falls right out, and it actually mucosalized and covered over. And in fact, she doesn't want to have the surgery anymore. She said, I'm the healthiest that I've been in a long time. I feel great. I'm playing tennis every day. I'm going out to eat with my friends. And so she does not want to have a surgery. And so I have this custom plate sitting here and ready to do her resection, and she doesn't want to have it. So that's sort of where we are. So even though I didn't mean for this wound care to be effective in this case, I had planned for a resection, it actually has been thus far, although she knows that she has a fracture and she has to have the surgery done. But right now it's not a displaced fracture, and she's not in pain, and she doesn't have an infection, and she's doing pretty well. So with that, I want to thank you for your attention. And I think we have a few minutes for questions.
Thank you very much, Dr. Aghaloo. Very nice presentation
Thank you.
tonight for us. So, abro la discusión, si ahí tenemos algunas preguntas. First of all, Dr. Nicolás Barrios asked about how is the differential diagnosis between stage 0 and other oral pathologies for avoid advance of ONJ. Regards, doctor.
Yeah, so that's a good question. So if you can find dental disease, and that's usually in the differential diagnosis, is it just an infection on a tooth, or is it ONJ? And that's where I think that the CBCT comes in very handy. And you're right. I mean, if someone just comes in with non-specific pain and no exposed bone, how do you know what in the world it is? And so the cone beam CT scan really helps a lot with that. And then if you see a dental disease etiology, then you can treat it either with a root canal or antibiotics or whatever. And then if you have any other evidence that it's ONJ, such as on the CBCT scan, then that's how you would treat it. Pretty much the same way, we'll be giving antibiotics. We'll be utilizing local wound care. A lot of times, if I figure out what tooth it's coming from, then I'll have the patient use like a rubber tip or some other hygiene aid that they can put in the chlorhexidine to clean around that area.
Thank you. Mm-hmm. So Dr. Viviana Toro asked about about the antibiotic therapy. So are you using an empiric approach? And then how often this approach fail?
So you mean empiric rather than just culturing it? Yeah. Exactly. So, I mean, unless there's a reason to think that these patients are all immunocompromised, at least somewhat, but the most effective therapy for most oral flora is going to be amoxicillin, right? So it's very rare that fails. If it does, then sometimes I need to add Flagyl or metronidazole. And so I probably have done that maybe out of the 450 to 500 patients I have, maybe like 10 times. That's it, where I've had to add metronidazole on top of the amoxicillin. The doxycycline is also quite effective. It's not as effective as amoxicillin. So I've had some patients where I actually ask them to get tested if they're really not convinced about their penicillin allergy. So I'll ask them to get an allergy test to really see if they are in fact allergic to penicillin, because I'd rather use that.
Yeah, thank you. So Dr. Donoso asked about, in the case with the big surgical resection, what is the prognosis of the patient considering the bone is in not the best condition? Do you consider the survival of the patient to choose that kind of approach?
Absolutely. I mean, this is really one of the main reasons that I didn't want to do the surgical resection, and I wanted to have another option, because you're absolutely right. Even if you look at the studies where surgical resection has been effective, a lot of those patients died, within 6 months to a year after their surgery. And, is that how they want to live the last 6 months to a year of their lives, potentially, after having a major surgical procedure? And so I discussed that a lot with my patients. And that's one of the reasons why this wound care approach to me is so important, because, I'd much rather be doing that than having a major surgery if the prognosis is not good, or if they're very frail. And I've honestly had patients that have had surgical resection go downhill significantly medically, because now they have had the surgery and they've been under general anesthesia. And now, it's even more difficult for, them to take care of the area or the caregiver or whatever. So honestly, that's a great question, because that's exactly what I was thinking when I was, coming up with this method of treatment.
Okay. So going back, Dr. Iturra, going back to the antibiotic therapy, she asked about what happened with the allergic to penicillin. What is
If they're allergic, then doxycycline is the next best. I really have not found that clindamycin is effective. I mean, to be honest, I don't love clindamycin anyway. We had done a study recently, a number of years ago, on patients who had sinus infections after sinus augmentation. And if they were allergic to penicillin, we were using clindamycin. And those patients didn't get better until we changed it to something else, such as Levaquin or azithromycin. So I'm not a big fan of clindamycin anyway, and I found doxycycline to be much more effective.
Okay, thank you. So Dr. Achiller asked about if you take any preventive consideration with patients under methotrexate treatment.
Yeah,
in ONJ.
That's a great question. So I think it was in maybe 2018 or 2017, we published a paper on, it was 6 patients that got ONJ from other medications other than antiresorptives. Methotrexate was one of those. I have 2 patients that have gotten osteonecrosis after methotrexate. So I do. So if I'm seeing patients that have methotrexate or any other type of immunosuppressant, I will usually give them antibiotics before I do an extraction. But certainly, I have seen ONJ in those patients. It's not very common. It's not nearly as common as the antiresorptives, but it can happen. So if they get that and they're on methotrexate, I treat them the same way with the local wound care and antibiotics if needed.
Okay.
The same thing goes actually for some of the other immunomodulators, right? Like the TNF alpha inhibitors or other immunotherapies that people are getting for the diseases such as rheumatoid arthritis and lupus and psoriasis and all those. So definitely something to think about.
Okay, thank you. So it's very often that we have a patient just 2 weeks before they start treatment with bisphosphonate or denosumab. So how long we should wait after tooth extraction? So what's your recommendation about the postoperative time to wait the healing of the alveolar socket?
If you can wait 2 months, that's ideal. So for example, if someone is getting denosumab for osteoporosis, I'll usually do it 5 months after they've had their last injection and then have them delay it another month. So it'll be 2 months until they get the next one. So you want at least some initial healing of the bone before you go in. So, in a cancer patient, I just don't do an extraction. Now, again, if they're waiting to have their cancer therapy, that's very tricky because they don't want to wait and they need that. So if they can't wait, then I'd probably see if I could try to do endo and cutting off the tooth rather than doing an extraction if they can't wait a couple months.
Okay. You mentioned a couple of times that there's a link between inflammation and the ONJ. So what do you think about the role of immune system in ONJ? Is there any, are we waiting for a curative therapy in this line?
So that's a good question. I mean, definitely one of the other major hypotheses, which may definitely have some merit, is the role of the immune system. I mean, there are studies looking at vitamin D deficiency and lack of innate immunity. And so certainly those are aspects. And even some of the animal studies have looked at using stem cell therapy for ONJ, and they have seen some success. So definitely that's a possibility. And I think that warrants further investigation for sure.
Okay. So, is there any other question? ¿Alguna pregunta a mano alzada que alguien quiera hacer? I think it's no more question today. So, well,
Muchas gracias. Está muy bien para ver todos y gracias por escuchándome y espero que pueda venir a Chile otra vez en la futura.
Encantados de recibirla, la profesora Aghaloo. Estamos muy agradecidos de su presentación.
Gracias. Hasta luego.
Hasta luego.
Chao.